All right, I think we will go ahead and get started. All right, so thank you everyone for joining us this evening. I am Courtney Gibson, one of the endocrine surgeons here at Yale, and joined with two colleagues, Sachin Majumdar, one of our medical endocrinologists, and Harry Deshpande, our medical oncologist. And we're here tonight to discuss adrenal tumors, diagnosis and management. And so I hope that this is informative for everyone. So just some basic objectives. We want to define what exactly an adrenal incidentalloma is and go into the workup and treatment for such incidentallomas. They vary from benign to functional to malignant. And we want to go over some imaging characteristics that raise concern for malignancy and what to do about that. And then we'll finish off by discussing multimodal therapy for those tumors that actually end up being cancers or carcinomas. We only have one disclosure. Harry, do you want to share your disclosure?
Yes, I am on the advisory board of these drug companies that are listed here. I won't be mentioning any off-label use of any medication, however, during this particular talk.
Okay, great. Thank you. So we'll start off with exactly what is an adrenal incidentalloma. So it's basically a nodule that's incidentally found during workup for other symptoms in a patient. And they're very commonly found on imaging studies. So a patient can come with some vague abdominal pain. They can present to the emergency room after a car accident and get, a chest, abdomen, pelvis. And a nodule just happens to be found in one of the adrenal glands in that patient that otherwise wouldn't have been known by the patient, meaning that the patient, as far as they know, were asymptomatic. Most of these incidentalomas are small, most are benign, and most are non-functional. When we're talking about the adrenal gland, the adrenal secretes various hormones that are important for our everyday functioning. But when a nodule forms, that nodule can secrete an excess hormone, particular hormone that can cause some symptoms. But most of these incidentalomas are benign and non-functional. The American Association of Endocrine Surgeons came up with guidelines in 2022, or the latest guidelines, on what to do about these adrenal incidentalomas. And they recommend that further diagnostic testing and evaluation is advised for nodules that are larger than 1 centimeter. And the two issues that you're going to be looking into in such nodules are evidence of hormonal excess. So is that nodule functional? Or evidence for potential malignancy? Are there some characteristics of that nodule that raise concern for malignancy? Or is there some particular history or risk factors in the patient that make you concerned that this could be a cancer? So imaging features are key to the evaluation of incidentally found adrenal nodules. We typically would like an adrenal protocol CT, and that simply is a CT that is undertaken by a non-contrast phase. And if the Hounsfield units, meaning how gray or the look of the nodule on imaging is greater than 10, then the recommendation is proceed with the venous phase, so 60 to 75 seconds after the initial contrast admission, and then administration, I'm sorry, and then a delayed phase, an additional 15 minutes after that. And what you're trying to look at is the washout characteristics of these incidentalomas. Those that wash out fairly quickly are considered to be benign nodules and less likely to work up as long as they're not functional, whereas those that have high Hounsfield units raise concern for malignancy and further evaluation is needed. So this is just a diagram depicting what we expect to see when we are looking at these incidentalomas. So sometimes patients go and, again, they weren't going specifically for the adrenal gland to be looked at, so they got an unenhanced or a non-contrast CT. And that alone would suffice if the Hounsfield units of that incidentally found nodules less than 10 is considered a benign adenoma. You don't have to investigate further. But if on that non-adrenal protocol CT, the Hounsfield units are greater than 10, we do recommend a second ultrasound that is what we call an adrenal protocol CT with the delayed washout, so that we can see after washout what the Hounsfield units are. And the absolute washout greater than 60% or relative washout greater than 40% leans back to this being a benign nodule, nothing to worry about. But if those washout numbers don't reach that threshold of 40 or 60%, then it's considered an indeterminate lesion, meaning we don't know if this is just a benign lesion or something more serious. And so you need more to look into the matter further. So what are some common benign non-functional adrenal tumors or adrenal incidentalomas? The most common are adrenal cysts. So in the left side here, you see there's an arrow, a white arrowhead in the center of this large adrenal cyst. And although it, looks large, this is probably about 6 centimeters or so, and they can actually grow quite large. This is a completely benign lesion, and this dark gray on the inside is fluid. So this is likely, usually serous fluid. Sometimes it could be a hemorrhagic cyst, but adrenal cysts are benign, and there is no further workup needed to evaluate these cysts. They also are usually asymptomatic, even when they are large, because they're fluid-filled sacs, and it's rare for them to cause local compressive symptoms or pain in the patient. The main concern about adrenal cysts is that they can rupture like any other cyst. They have risk of rupture. The overall risk of rupture is not such that surgical resection is recommended. So adrenal cysts are not recommended to be routinely resected unless they are very, very large and at a higher risk of rupture, or in the rare instance where, because of the size, they are causing some local compression, which again is rare. Over to the right, we have a myelolipoma of the adrenal gland. So for those who aren't as familiar with what a CAT scan looks like, what the different textures look like. Fat is black. So when you look at this patient here, they have a large dark subcutaneous area, that's subcutaneous fatty tissue. And then around the organs, this is the kidney here on the right and the liver and the intestines anteriorly around 12 o'clock. So surrounding these organs, you see darkness, you see fat. That represents fat, so visceral fat surrounding these organs. Over here on the right, where the adrenal gland is, you can see some adrenal tissue along the lining or along the border, but then there's a thin lining of tissue, and inside you see this dark black area that looks similar to the surrounding fatty area. So that's a myelolipoma as opposed to the fluid-filled center that you see with the adrenal cysts. Myelolipomas, like adrenal cysts, are benign. So if they are diagnosed on imaging studies as a myelolipoma, this is a benign finding, and again, there's no risk of malignancy in these tumors. Now, these also can grow quite large, and because they have more substance than just cystic or fluid contents, they can, over time, cause some local compressive symptoms. I think particularly on the right where there's less room because the liver is there. So these can grow 10, 15 centimeters or so. And at that point, they can cause some local compression. A patient may present with some back pain or some flank pain. And referral for evaluation for potential surgery is reasonable, but there's no malignant potential, so that's not why we would be considering resection in these patients. So again, from the American Association of Endocrine Surgeons, their recommendation is to avoid resection of myelolipomas or adrenal cysts that have pathognomonic imaging features consistent with a cyst or a myelolipoma, unless there are symptoms of mass effect, meaning local compression, which again is rare. They say that you can consider resection if there's some indeterminate imaging features, so you can't clearly say it's a cyst. It may have a solid component to it, or you can't clearly say it's a myelolipoma. Maybe the fat content within it is not significant enough or high enough to fully say it's a myelolipoma. Then you can consider an interval imaging study to try and differentiate and see if this is a benign finding or something more concerning. So overall, for benign adrenal tumors, the recommendations are, if it's a biochemically non-functioning tumor, and the Hounsfeld units are less than 10 or the size is less than 4, no imaging or follow-up is required. If it is a non-functional tumor, the recommendation is to repeat cortisol, assessment for cortisol in 2 to 5 years. So if it's a small adenoma, maybe a small solid lesion, but is not functional, they recommend repeating an assessment over time. Or if the patient starts to develop symptoms of adrenal hormonal excess, then you can investigate earlier. For sizes 1 through 4 centimeters with indeterminate features or history of malignancy, we want closer follow-up. So we usually recommend a repeat imaging study within 6 to 12 months just to see if there's interval growth of that 1 to 4 centimeter incidentalloma, or if there's a change in the characteristics. The borders may look a little bit more irregular. There's more of a solid component. And again, keeping in mind what the absolute washout number should be. So for an indeterminate nodule, though those don't meet that absolute washout of 40 and 60%. And so they're called indeterminate and raise concern for malignancy, but don't, guarantee malignancy. And then they recommend to consider additional imaging, alternative imaging like an MRI or a PET CT to further evaluate these nodules and get a better idea of the malignant potential for these nodules. All right, I'm going to turn it over to Dr. Majumdar to go over functional adrenal tumors.
Okay, thanks, Dr. Gibson. Okay, so I was going to tell you guys about the adrenal experience here. And, just like an action movie back in the day where you would go and eat like salty popcorn and have sweet sodas and things like that, and all the crazy stuff that happens in a movie, that's how we think of, what the adrenal can do. And this actress, by the way, is a Yale graduate. And just as an aside, this guy jumping down, I think he has acromegaly, but that's a pituitary condition, so we won't talk about that today. But, moving on, so for the next slide, so the adrenal gland, just like the action movie thing, we have to think of salt, sugar, sex steroids, and adrenaline. And one can imagine that, it produces these hormones in different layers that control these things. And so if one of these layers overgrows and makes a salt-retaining hormone, your blood pressure can go high. Or cortisol, it can break down your muscle and thin out your skin and make your blood sugar go high. And then, of course, adrenaline can make your heart beat fast and blood pressure go high. So all of these things are what we typically, have to screen for when we come across these tumors. And, the way this has evolved was that historically, we know from history of endocrine conditions that we usually get the tip of the iceberg, a long time ago, because people didn't have all these lab tests and studies that we do now, but they really knew if somebody was very extreme. So early descriptions of aldosteronism where hypertension, was prevalent with low potassium levels, alkalosis. One of the first patients described had periodic paralysis because of low potassium. And then there's Cushing syndrome where you see the overt, breaking down of muscle tissue, fat gain, people with bruises, high blood pressure, high blood sugar, all those extreme features. And then finally, pheochromocytoma, the classic things of, headaches, palpitations, sweating, tremors, and so forth. And so, these conditions came to be characterized by first people looking at their extreme forms. But now, we know so much more in terms of detail that a lot of these forms are, these conditions show up in milder forms or look different. So you can't go by these extreme descriptions always. And when you find an adrenal, growth, we need to think about, screening for all these because these things can masquerade amongst, for example, with aldosteronism, people with hypertension, the rule is normal potassium. And when you look at people with high, high blood pressure, you may find that this condition affects anywhere from 5 to 25% of people with high blood pressure, depending on, which population you're looking at. And then hypercortisolism. We see plenty of people with hypertension, diabetes, obesity, elevated lipids, osteoporosis, and masquerading amongst many of these may be, this hidden, mild excess of cortisol that never makes it to the extreme levels, but is really affecting people. And then for pheochromocytomas, these things present variably. They don't have to have these episodes. You can have sustained, elevations in blood pressure, sometimes normal blood pressure, and sometimes the hormones themselves aren't that elevated. And we usually make a diagnosis based on the hormone metabolites, which I'll mention later. So some general numbers when you come across these tumors are, 1 to 10% may be associated with aldosteronism, 20 to 50% with mild excess cortisol called mild autonomous cortisol secretion, maybe 1 to 4% overt, and then for pheochromocytoma, maybe 1 to 5%. So how do we sort out and figure this out? Well, there's a general concept of the adrenal gland getting stimulated by a stressor. So the way it works is there's some stimulant, and you can imagine getting into a car accident or having a surgeon do a surgery without anesthesia. You're going to be stressed out. And, the pituitary will send ACTH to make cortisol. The adrenal gland will get sympathetic nervous system activation and you'll make adrenaline. And then if you have low blood pressure, the renin-angiotensin system kicks in to make, aldosterone. So this is how it works. There's usually a stimulant and then there's the adrenal hormone. But when we're looking at isolated adenomas, we want to know, is there an adrenal hormone coming from it? And then we look back and say, is there a stimulant for this hormone when we measure it? And then sometimes we go back and try to suppress the adrenal hormone and see if it's responding normally. So basically, the context for testing for a lot of these things is you don't want to test someone when they've just had a car accident or got into a fight with someone or come into the hospital with a stroke, because these stress hormones are going to be elevated then. We try to test under conditions that, someone's calm. And then why do they have a very elevated stress hormone? And we try to look at the stimulus, for example, ACTH or renin, to see if that's, appropriately elevated or low. So moving forward, so how do we ask these questions? What is this adrenal nodule making? Well, we can look at, the three general things we look at are aldosterone, cortisol, and epinephrine, norepinephrine. And for aldosterone, we sort of look forward and we check aldosterone and the stimulant for aldosterone, which is renin activity. So if that activity is low, then we're going to look back at that nodule and say this thing may be making aldosterone when it's not supposed to. For cortisol, it's a little bit different because the stimulant for cortisol, which is ACTH, isn't always as good, in predicting the activity and suppression or, from these nodules. So we actually try to suppress cortisol. And we do that by giving a steroid, dexamethasone. So we try to lower the cortisol. If it doesn't respond, we're going to think, again, there's something not working properly. This nodule is just making stuff, uncontrolled. And then when we get to catecholamines like epinephrine and norepinephrine, they're fairly short-lived in the blood and they may be released sporadically, but these tumors make them continuously and they get deactivated continuously. So those deactivated metabolites are what we use for a diagnosis because they're always being secreted into the blood, and we can measure those in the blood and the urine. So that's metanephrines and norepinephrines. So some different ways of getting at these hormones. So why is primary aldosterone is important? If you look at people with hypertension, even the same levels of elevations in blood pressure, people with primary aldosteronism have higher rates of strokes, MIs, and atrial fibrillation. So it's important to try to select these patients out from the hypertensive crowd. And a perfect time for that is when you find someone with an adrenal adenoma and hypertension. So the general screening, and to be honest, there's a lot that's in flux. There was a paper that came out in 2024 making some kind of recommendations in screening. The Endocrine Society guidelines are from 2016. And so things are changing a little bit, but I just wanted to leave off a reasonable approach to assessing for primary aldosteronism. So this is what every primary, practitioner should be able to look at and do. So one is we get a renin activity, and if it's low, we also look at aldosterone levels then. So renin's the stimulant. So if aldosterone happens to be low, then, we say either repeat the test or we really don't think that this, nodule is making aldosterone. Once aldosterone levels get to be 5, 15, over 15, we really start to think that, this is going along with autonomous secretion of aldosterone. And then we look forward to say, do we have the ability to do some more detailed testing and evaluation? So, and here's where, specialist referral and testing resources are important. So one of the things is, here at Yale, we can do advanced testing and we have great surgeons like Dr. Gibson. But in some areas and perhaps some patients, surgery may not be an option for these people. And so in those circumstances, when testing and surgery may not be an option, we usually recommend, medical therapy, and that's the general recommendation. But if it is an option and the patient's a good surgical candidate, we have to do a little bit more in terms of testing before, actually taking them to surgery. So we do what's called confirmatory testing. And again, just like giving a steroid to lower cortisol, we give a whole bunch of salt to see if we can lower aldosterone. And one of the more convenient tests that we can do here at Yale is, infuse 2 liters of saline over about 4 hours. And then we look to see if we lowered the aldosterone in the blood. And So when we do that, we can say, if aldosterone's over 10, that's a positive test. We can't suppress aldosterone. So highly likely that this is, confirmed, and surgery, if it ends up in the right location, would be a cure potentially. The other way to look at suppressing aldosterone, which I sometimes do with my patients, it's a little bit easier than bringing them in, is doing a salt loading test. And, we're supposed to eat, less than 5 grams, or some people say 2,300 milligrams a day of sodium. That's about what's in a teaspoon of salt. So usually we give people, the recommendation is to give about 2 teaspoons of salt per day. But I don't give that much. We just say, eat your normal diet. And I, for example, will tell someone to have an additional teaspoon of salt per day for the saline, for the 24-hour urine collection and salt loading study. So that's the suppression test. So we give a higher salt diet, or add in a little extra salt for a couple days, and then do a urine. And then we look to see if aldosterone has been suppressed in the urine. And if it's elevated in the urine, we'll say you've confirmed, that this is, true primary aldosteronism. And then we take a hard look at the patient again and say, is this person a surgical candidate or not? And if they are a surgical candidate, that's where we start thinking about, okay, and Dr. Gibson will not take out someone's adrenal unless she's sure she's, going to do the right thing. And so that's where adrenal vein sampling comes in, where we ask, is excess aldosterone really coming from this nodule, or is it coming from both sides and we're just being fooled here? So this is a fairly complicated procedure. So they get patients come in, they get a catheter put in the femoral vein, and then that goes up into the adrenal veins, and blood is sampled. And the goal is to try to figure out, is excess aldosterone coming from one side or from the other? And that can really help guide us towards medical versus surgical therapy. So one thing in the guidelines is that, younger patients or people less than 45 with a nodule and very severe aldosteronism may not need this. So that's also something to consider. And so you may ask, why is it important to do the vein sampling if you have an obvious nodule on a CT scan or another imaging study? Is because the obvious nodule we can see, but sometimes we can't see smaller nodules or smaller clusters of cells in the other adrenal gland. And that may show up so if you can put the next thing. So see, these nodules may not be seen on CT imaging. So the only way to really get at that is to do the adrenal vein sampling. And so just briefly about adrenal Cushing. So people are familiar with the more extreme forms of Cushing's with, again, body composition changes, thinning of the skin, bruising and so forth. But there's also milder autonomous cortisol secretion, which probably makes up the bulk of what's going on with these adrenal growths. And so we have to get hints from what's in the blood. And sometimes when we get patients and we do initial labs, you might check aldosterone and renin and things for pheochromocytoma. We also check things like cortisol and ACTH. Because if an adrenal nodule is making cortisol, it'll tend to suppress the pituitary gland. And that ends up, creating a situation where you have chronically low levels of ACTH. So that means the other adrenal gland tends not to make as much steroid. And we may have this picture where we have a nice cortisol level, low ACTH, and a lower DHEA sulfate. I should mention, if DHEA sulfate ever comes back elevated in the setting of one of these tumors, we start to think of cortical carcinoma, because those are classic for making several different hormones. And they can make cortisol plus DHEA sulfate. But the general picture of, cortisol, low ACTH, DHEA sulfate is helpful. But the test of choice for hypercortisolism with these adrenal growths is a dexamethasone suppression test. And again, this is something that, you can do in primary care fairly, easily. Someone takes dexamethasone around 11 p.m. to midnight and then gets labs the next day. And those labs are dexamethasone and cortisol. And the key is, if the cortisol level goes to less than 1.8, we consider that normal. On the other hand, it's really important to know, younger women or, women on birth control or pregnancy, if you check a cortisol level, it's going to be high, and this is not a good test then. Sometimes that's also true for chronic hepatitis, because the binding proteins for cortisol then are elevated. So you might get a false, abnormal test in those circumstances. On the other side, sometimes when albumin is low or people have cirrhosis or nephrotic syndrome, you might get falsely low results or falsely normal results. So in those circumstances, it's then reasonable to do things like saliva testing and urinary cortisol, even though they're not as good as doing a DEX suppression test. That's all you can really do in those patients, in addition to putting together the clinical picture. And sometimes in that scenario, the cortisol, ACTH, and DHA sulfate levels could be helpful too.
I just want to add, it's important that you're measuring that dexamethasone the next morning. And that's because sometimes patients forget that they were supposed to take that milligram tablet the evening before. And so the next morning you just get a cortisol level. You don't know if they actually took the pill the evening before. So that's why the dexamethasone is measured to make sure that the patient actually took it as they were instructed to do so.
Absolutely. Yeah. Thanks for pointing that out. And so some people may ask, like, what does this cortisol mean after taking dexamethasone? And this is one study where they took people in their, 50s or so who had failed, or had gone through dexamethasone suppression tests with these adrenal incidentalomas. And what they found was there was a separation. So mortality was increased when the cortisol after dexamethasone was 3 or higher. We usually say less than 1.8 that's generally accepted as normal. What do we do with these more subtle cases where it's a little bit elevated? And here's where we struggle. Do you put this person through a surgery or put them on medications? But these are the things we're looking for. So, historically, the higher the level of cortisol after dexamethasone, the worse the features, but it's not true for everyone. Some people may have, lower levels of cortisol or not as high as 5, and they still may have hypertension, heart disease, and, all kinds of other things that might improve. So that's some of the thinking that goes into, interpretation of these tests. So just going through some other things quickly, this topic of ACTH independent Cushing's, when there's one adrenal nodule and it's making excess cortisol, it's reasonable to take that out. If there's nodules on both sides, then the question of taking out both adrenal glands, raises some concern for everyone, because one of the downsides is then you have lifelong adrenal insufficiency. So sometimes, we say take out the larger side, the biggest lesion. Sometimes we do adrenal vein sampling, to try to sort that out. Sometimes you can take one out, and if the other one's still really active, we have medications we can give. And if someone's not a surgical candidate, there are some medications around that we can try to use to lower cortisol production. And then just, mild autonomous cortisol secretion I had mentioned before, with the cortisol being 1.8 and higher, masquerading in the general population and being fairly common. Okay, so finally, I just finish up with pheochromocytomas. And again, these secrete catecholamines, adrenaline, coming from the center of the adrenal gland. And then we kind of lump these together with paragangliomas, which can sometimes secrete catecholamines as well, but they develop from the sympathetic and parasympathetic ganglia. So for pheochromocytoma, the initial testing here is for urinary or plasma metanephrines and norepinephrines, and usually we're looking for levels 3 to 4 times, above normal. False positive tests are important to consider in people on tricyclic antidepressants, SNRIs, sympathomimetics, and some other medications out there. So it's important to look through a medication list. Now, these tumors really need to go to surgery. And so there's some preparation involved, and that typically involves, really controlling blood pressure. Usually alpha blocker is, the first choice, maybe a beta blocker, sometimes calcium, and then salt loading, so their volume replete, and then ultimately treatment is surgery. And then, just to touch on this, a lot of these tumors could be large enough or, good enough to make epinephrine and norepinephrine, but those catecholamines may never make it to the blood because they get deactivated into metabolites. So, and that's reported maybe up into 30% of these tumors. So the metabolites that we measure are, norepinephrines and metanephrines, because those last longer, they're made continuously, and so those are the ones that are to be used for diagnostic purposes. We don't typically get 3-methoxytyramine here just because historically we haven't sent it out, but that's another test that one can get. So just to kind of finish up here, so when to test if you find an incidentaloma. So there is the rules, there are rules for cost-effective approach to this. When people come to see endocrine, we'll tend to do more testing because we're the last stop for these, especially if they're going to go to surgery. So everyone wants to make sure we've kind of tested all the patients. But in primary care, if somebody has hypertension or unexplained hypokalemia, completely appropriate to check for aldosteronism. If you have low blood pressure or normal blood pressure, that's where it's maybe not necessary. For hypercortisolism, everyone should be checked for excess cortisol. And for pheochromocytoma, if the adrenal lesion has greater than or equal to 10 Hounsfield units on non-contrast CT, or if it's not compatible with a benign lesion on MRI, then that's indicated. And then how do you screen? So aldosterone-renin ratio, ideally in the morning before taking other medications, but if your patient's leaving the office and they're not going to get their labs otherwise, it's okay to do in the afternoon. For hypercortisolism, we recommend the DEX suppression test, but just be aware of the false, positives with estrogen. That seems to be a big one. Then saliva and urine are alternatives. And then for plasma, metanephrines and normetanephrines. And if those are positive or equivocal, we usually do a 24-hour urine. And just to touch very quickly, I usually have people draw their blood first. So whatever blood test you're going to get, do those first. Once they're collected, that's when you prescribe the dexamethasone and order cortisol for that. Because if you try to do everything at once, it will not happen correctly. So always get your labs at baseline. Once the blood has been drawn, then go ahead and do the dexamethasone stuff so it doesn't get mixed up. And I think I will end it there and turn it over to Dr. Deshpande.
Sorry, I always have trouble coming off mute, but thank you. And that was great. We've heard about the benign adrenal tumors, and I'm just going to mention one of the malignant ones. We've heard about pheochromocytoma, and there's a bit of a debate on when to call pheochromocytomas benign or malignant. So I'm not going to get into that in too much detail, other than to say there are some very exciting new treatments for pheochromocytoma in the radiopharmaceutical field. And we have someone who's very interested in neuroendocrine tumors here, Dr. Coons, and I would recommend her if anyone has a malignant pheo that needs to be treated. But for other malignant adrenal tumors, just like for anywhere else in the body, we have to decide, are they primary or secondary? The primary tumor we're going to talk about today is the adrenocortical carcinoma. This is a rare tumor with a poor prognosis unless you catch it very early. And many of them do secrete multiple adrenal hormones, as has been mentioned. Secondary tumors can occur, and they're actually probably more common. They occur from any tumor anywhere in the body. Typically, the most common is from lung cancer. It seems to have a predilection to metastasize to the adrenal gland, but we also see adrenal metastases from kidneys, melanoma cancers, sarcomas, esophageal cancer, and others as well. Next slide. So adrenocortical cancer is a true 1 in a million cancer. It does have a higher incidence in some countries, such as Brazil, and it's often, or I should say, it can be associated with some familial syndromes, which many of you will be familiar with, including the Li-Fraumeni syndrome. So if you have a patient who has either a personal or a family history of breast cancer or leukemia or sarcoma, then it's worth thinking, if you see an adrenal nodule of adrenocortical cancer in the back of your head, the back of your mind, just to think, could this be one? As mentioned, the majority are secretory tumors, and as mentioned, they do have a poor prognosis if they're very large or they metastasize. But if you are lucky enough to catch these at a small size and an early stage, then the prognosis is actually very good. The treatment, again, like for pheos, is surgery is the main treatment, but sometimes we'll add other medications or treatments to improve the survival or progression-free survival And the one that I mainly use is a treatment called Midotane. And as Dr. Majumdar and Dr. Gibson have already mentioned, prior to doing any biopsy for a suspected adrenocortical cancer, you do have to work up for a pheochromocytoma. Next slide. Yes. So Midotane is an adrenocorticolytic drug. Its trade name is Lysodren. It's actually similar, unfortunately, to DDT or insecticide, which is one of the first things patients see when they Google this medication. They come in and say, how come you're giving me insecticide? Which we're not, but it's a similar medication. It's very effective in stopping the adrenal gland working, and this is why I do have to have patients see either Dr. Majumdar or one of his colleagues in endocrinology to replace whatever I'm stopping being made. It also has a lot of side effects. Unfortunately, it's a pill that's taken sometimes 6 pills a day. It can cause vomiting, diarrhea, rash, anorexia, but also confusion, poor concentration, and depression. And these are patients who you really have to stay on top of. Some of them can be quite young and prone to some of those side effects, even without the medication. So if you are seeing these patients along with me in primary care, then I really do appreciate your help in sometimes prescribing antidepressants and other things just to get them through the treatment. Because it's a very rare disease, a 1 in a million disease, we can't do the sort of studies that we do in breast cancer and lung cancer, colon cancer, where we can say, if you take patients who've had surgery and then give them an adjuvant treatment, a treatment after surgery, is there a benefit to do that? And one of the reasons for that is you often need many, many patients in each arm to prove a benefit. So the only study that's really been done is a retrospective study. And just to give you an idea of the scope of how difficult the study was to do, it was done in 47 centers, and it took 20 years to complete the study to get 177 patients. And you can imagine during that time, medicine changes a huge amount. So this study has been criticized for some centers having some ways of doing things and other centers having other ways. But you can see that the patients who got Midotane on average for 4 years after surgery, the progression-free survival, that's PFS, was significantly increased, and the overall survival was almost double. So I do offer this medication, despite all its problems with side effects, to patients who have a very high proliferation rate, that's the Ki-67, those who had tumor spillage during surgery, capsular invasion, or a very large size. Next slide. And this is one of, I think, Dr. Gibson's surgeries that she did, where you can see how large this particular tumor was and how ugly it looks. It looks very heterogeneous. It doesn't look the same all the way through, and this is because of necrosis and hemorrhage, and often it's locally invasive, making surgery very difficult. Next slide. So if you do have patients with stage 4 or metastatic disease, even though the cancer has spread to other parts of the body, we still sometimes do surgery. I'll sometimes send them to Dr. Gibson if she hasn't seen them already and say, I know this person's got metastatic disease, but is this someone who we should think about surgery? And if you look back at some of the studies, the survival rates don't change a lot, but what you do is take out a very large tumor that could be causing pain because of its size, and also maybe causing hormone symptoms, excessive hormones that are refractory to most medical treatments. So I usually will present our case. We have an excellent tumor board where all 3 of us are, and get the opinion of Dr. Majumdar, Dr. Gibson on what the best outcome would be. I don't know, Courtney, if you want to say anything else about surgery in that setting.
Yeah, I think you brought up two very important points. So even with metastatic disease and, with the 5-year survival rates being so poor, many times these tumors are very large, and the patients true indeed have pain from local compressive symptoms of these tumors. So compressing the vena cava or the liver or the kidneys. And then the second thing you mentioned about the hormonal excess, sometimes these tumors are so large and they're secreting so much cortisol or androgenic steroids. That's a common one they secrete as well too, that the patients are very symptomatic for that. So a debulking procedure, whereas, if there's two different reasons to go in surgically for adrenal cortical carcinoma. One is to try and get clear margins, what we call an R0 resection, no visible disease at the end of the case. But in a case like this, where there's metastatic disease, we would do palliative surgery or a debulking procedure where you're not going to get all the cancer out. You want to remove enough to decrease that excess hormonal burden and also to decrease the pain component of it. But it's a major surgery to undergo, and patients need to understand the goals of treatment when surgery is involved.
Thank you. Next slide. So if a patient is being considered for surgery, sometimes Dr. Gibson might send the patient back to me, even though they don't have metastatic disease, but it may be at a size where if we can make the cancer a little bit smaller, then it might make surgery more feasible. Or if we give treatment such as chemotherapy and the disease gets much, much worse very quickly, it might save them from having a surgery that would be very difficult to do and maybe not completely possible. So we do sometimes do what we call neoadjuvant systemic treatment. And what this means is giving chemotherapy before surgery. Now, chemotherapy for adrenocortical cancer doesn't usually make the cancer much smaller, but if it can even make it a little bit smaller, it might help a borderline case into a resectable case. And this is one study that Dr. Gibson had quoted. I don't know if you want to say a little bit about that.
Oh yeah, just so when we talked about R0 resection, that means, visibly negative margins at the end of the procedure. And so sometimes that's just not feasible. And so it is recommended, surgery is recommended for adrenal cortical carcinoma. It's the best chance of potential cure or prolongation of life when it can be completed. But in cases where the initially on imaging, you see invasion into the liver or the vena cava or even the kidney, those would be cases where neoadjuvant chemotherapy could be of some benefit to shrink down the tumor some so that the surgical debulking will be not as large of an undertaking as it otherwise would be. And again, we see here the strong recommendation and low quality evidence. The low quality evidence is, just like Dr. Deshpande mentioned, is because these cancers are so rare. It's really hard to get, a significant number of patients who've undergone one treatment, neoadjuvant, followed by surgery versus surgery and then neoadjuvant, to really have a comparison group.
And finally, this is talking about metastatic disease. So unfortunately, metastatic adrenocortical cancer is incurable, but we are doing a little bit better with some of our treatments. The treatment I use today is what's used all over the country, which is a combination of 3 chemotherapies: etoposide, doxorubicin, and cisplatin, in combination with midostaurin, which was shown to be better than what was the old standard of a very old chemotherapy, streptozotocin, with midostaurin. But you can see the numbers here are not very good. The overall survival is about 15 months with the treatment that most of us tend to use first. And so we do need new treatments. There are a lot of treatments under investigation. Again, because the numbers are so small, most of these are what we call phase 2 trials, so they're not randomized against the old standards. But we are using immunotherapy and second-line treatments, as well as some targeted therapies as well. And that's metastatic disease.
All right. So, in summary, adrenal tumors range from benign to malignant. So an adrenal incidentalloma can be any of or all of the above. So a benign lesion that's non-functional, a benign lesion that is functional and causing some symptoms, or a malignant lesion which can be functional or non-functional. And so this summary table just talks about some of the symptoms that you may see depending on the functionality of the tumor and whether or not you're dealing with an adrenal cortical carcinoma or metastasis. And it's important to know if you see a large tumor, 5 centimeters or larger, that should really raise concern for malignancy or pheochromocytomas can be tend to be quite large as well, whereas aldosterenomas tend to be small, 1 or 2 centimeters, and then Cushing's or tumors secreting cortisol can be somewhere in between those, maybe 3 to 5 centimeters. So I think we have a few more minutes left, and we want to open it up for discussion, but we'll go over 2 quick case presentations. All right, so the first, this was in a 78-year-old female with significant past medical history who was found to have an incidental 3-centimeter adrenal tumor. Symptom-wise, she complained of mood swings, fatigues, and anxiety. And on physical exam, she had overt Cushing's features. And so by that, I mean, the typical large stretch marks that are discolored, they kind of have a purplish hue. She had abnormal fat distribution between her scapulae, which is called, textbook, the buffalo hump, and had a history of easy bruising, where she said she would wake up or go in the bathroom and notice that there's bruises on her arms and legs, and she didn't recall falling or hitting herself, and so wasn't sure where they came from. So she underwent diagnostic testing by Dr. Majumdar, and as he mentioned earlier, the dexamethasone suppression test was utilized, and she did not suppress. So remember that number. If it's less than 1.8, that's considered appropriate suppression after you give someone steroids. And her AM cortisol was 6.8, so well above that threshold. Also, she had elevated midnight salivary cortisol, which is another test that can be done. As always, we want to make sure we're not missing a pheochromocytoma, and her metanephrines and aldosterone levels were checked, and those were also normal. If either one of those were also elevated, then that would raise our concern for malignancy. Malignant adrenal cortical carcinoma usually secretes more than one hormone. Sometimes they can secrete none, but 2/3 of them secrete hormones, and the majority of those are more than one hormone. So it may be, DHEAS and cortisol, or aldosterone and cortisol. So if you find elevation in more than one adrenal hormone, that raises concern for malignancy. So we got a CAT scan of the patient here. I don't know how well these slides can show. Oh, yeah, I can see it here. So here on the right, you can see her liver in this upper image, and adjacent to the liver is this rounded or oval-shaped lesion. A normal adrenal gland should look like a wishbone, an upside-down wishbone, or a small wedge of cheese. And when they become rounded and oval like this, that's a tumor that has formed within them. And then in view here, you can see its proximity to the liver right here. So for her, we did a right retroperitoneoscopic adrenalectomy. That's just a fancy way of saying a laparoscopic procedure, but through the back. So minimally invasive procedure, I should say, through the back instead of through the abdomen. The advantages of that is more direct access. So in the retroperitoneum, there's fewer organs. There's the kidneys, the adrenal glands, and the blood supply to those organs. Whereas anteriorly, you have intestines, liver, all your other abdominal organs that you think of. And this patient had some prior abdominal surgery, which would have made the anterior approach, riskier with scar tissue. So the case itself went pretty smoothly and was uneventful. So here, if you can see, just a clip of a few seconds. So this is in the retroperitoneum, and what is depicted here is this orangey looking rounded adrenal mass. Below me down at 6 o'clock, you can just see the posterior aspect of her kidney. So I've kind of dissected the kidney down, and the adrenal mass is hanging up by the ceiling on the back side of her, which is helpful, kind of serves as an additional arm to help with dissection. And this was a pretty straightforward dissection The Cushing's glands tend to be a bit friable, so they can break easily. So I try to minimize manipulation of the glands and really dissect the tissue away from them. Usually, so this was a right sided lesion. So the adrenal vein is coming directly up the inferior vena cava, which you don't see in here. So you have to be careful with those dissections. But the case went very smoothly, and the patient, this is at the end of the case where we're just collecting the specimen in an endocash bag, still within the patient before we remove it, to make sure we don't have tumor spillage, even when it's a benign lesion. And okay, sorry, go faster here. And this case 2, this was a young, healthy female, just only past medical history significant for Hashimoto's disease. And symptoms she described, some headaches and palpitations. And she actually only had an abdominal CT scan, was because she developed COVID and was very sick from COVID and got a CAT scan for that. And lo and behold, a large adrenal mass was found. So what you can see here, earlier when we were talking about tissue planes, so the blackness here is actually lung. So air and fat show up black on a CAT scan. So this is just the lower lung fields, and you can see now the diaphragm as we enter the abdominal cavity. And what we see here, there's a loss of fat planes. So this large mass here is indistinguishable from the liver. And if you saw a few more cuts, you would see that as well. And then over here too, it's encroaching upon the superior pole of the kidney. You kind of lose your plane in the liver as you get more medial here, and even the diaphragm, hard to say, is it invading the diaphragm or not? So she had a functional hormonal workup, and her dopamine levels were elevated, and her presentation was consistent with adrenal corticocarcinoma. So we planned for an open resection. She's a thin patient, young, healthy patient. She tolerated the procedure well, and we were able to get an R0 resection in her. I don't know if Sachin or Harry, do you want to add? You both have been very much involved in her care preoperatively and postoperatively.
Yeah, this is someone who, because of the size of the tumor, and I think you have the pathology report on the next slide. So she did have some features that would tell us that surgery alone is unlikely to do as well as maybe surgery plus Midotane. So this is someone who we would consider Midotane because of the size and the just the number of mitoses and necrosis in the tumor.
All right.
I think now with her mitotane therapy, her adrenals are shutting down, and she's on cortisol, hydrocortisone now. So, and I think I'm seeing her this week. So far when I've seen her, she's been doing pretty well, holding up with treatment.
I think that's an important point too. The mitotane is used to kind of suppress the function of the the cancerous gland is now removed, but to suppress growth of any potential cells that could be left behind, especially in a large tumor like this. But that mitotane is going to kill off the function of the healthy remaining adrenal gland. And so those patients are going to develop adrenal insufficiency and need supplementation. So that's something that's important to have patients aware of as well. All right, so surgery is the mainstay for adrenal corticocarcinoma, but adjuvant therapies are often utilized because these tumors are very large and they're at high risk of recurrence or persistent disease. And more clinical trials are needed to find better treatment options for these patients. All right. So I think we've approached the end of our time here, and we are open to any questions if anyone has questions. All right. If not, we thank you very much for tuning in. We thank you for your time. And, I think the most important take homes are, if an adrenal nodule is incidentally found, there are the main two things you want to try and rule out or differentiate. Is this potentially a cancer, whether primary or secondary in the adrenal gland? And is this a functional tumor? And so there's some basic screening tests that we've gone through tonight that should be helpful. But if nothing else, or if it doesn't come to memory, you can always reach out to any one of us and just, ask a question. I'm happy to review imaging to say, is this something that should be looked into further, or is this nothing to be concerned about? So we're happy to kind of answer any questions anytime you run across these lesions, and we definitely appreciate your care for these patients, and both preoperatively or treatment and post, because you guys have the most contact with these patients and have ongoing contact with them, which is helpful for us as well. All right. Thank you very much, and everyone have a great evening.
All right. Thank you, guys.
Thank you.